Gianni, the screen is yours.
Okay, I'm ready. Thank you for the invitation to be here. And I will try to share with you what I learned on this, that is one of the most neurophysiological or anatomo-physiological surgery in all our field. So to that I don't know exactly me, and that's from the beginning, and that's from now. And if you want to know why I became a neurosurgeon, you can get this contribution, this paper. Microvascular decompression. I mean, the main problem of the neurophysiological disease of cranial nerve is trigeminal neuralgia, the most epidemiologically important. We have two techniques. One is a percutaneous one. We have also radiosurgery. We see at the end, and in the open procedure. But we have to talk today about the open procedure. If we have time, we will go to give some advice for the percutaneous technique. So what we learn from this kind of surgery. This is from Lawton, and you see here for the young people that maybe are listening to us, in this small field that is no more than 15 millimeters, you have everything from the fifth nerve to the 11th nerve, and that is trigeminal neuralgia, and functional hemispasmus, glossopharyngeal neuralgia, Meniere syndrome, and so on and so. So, sorry, let's go ahead. A little bit of history. We started with the lesioning from 2 centuries ago, and till the beginning, the half of the last centuries, where Tarnoy tried to propose decompression of the nerve intradurally in the Gasserian ganglion, and what was Gardner but mainly Janetta that developed this approach. This is our series. My personal series is one on the bracket, and that is the, as I told before, the pathology that we can treat with this kind of approach. The three are the main one, and the last one are the less easy to find. What is the pathogenic hypothesis? The apoptic transmission among the nerve at the entry zone, the fifth nerve, at the entry zone of the fascial nerve that is in the protuberential sulcus. And maybe for the Meniere syndrome and the neuralgia of intermediate nerve is nerve distortion. The entry zone is very important because there is a one characteristic, the presence of glial cell for a few millimeters before they get the real nerve, and that's maybe the reason why we have the apoptic induction. Nevertheless, we have to understand that there is in peripheral nerve, there is conflict that gives a similar situation. This was one case that we published, is about the anterior interosseous nerve. So that is something that can be seen for many other nerves. The other problem is that for trigeminal neuralgia and glossopharyngeal and the nuclei, what they play there. And we know that NBD is working also in multiple sclerosis, is working in a typical trigeminal pain, sometimes is working in trigeminal autonomic cephalalgia. And that is not a conflict, it's something that has to deal with the nuclei. So let's go to the surgery. That is very important that the MRI is done in a very good way, and you can see the conflict. And my suggestion is never trust your radiologist. See with your eyes what is in this particular patient. And we find out that sometimes you are in a disagreement with a neuroradiologist. How to do it? Is a very simple incision in the retromastoid region,
Very small is a craniotomy, is a mini or micro craniotomy. And you found a kind of corridor because the cerebellum is going down, and the surgeon can go through there without touching, without destroying or damaging the surface of the cerebellum. And we see what are the tips and tricks on down that. So positioning is very, very important, because when, as in all surgery, in all neurosurgery, but in this case is very, very important, because if you want to do a micro craniotomy, you have to be sure that you can get where you want to go. This is the landmarks, is the superior, the sagittal, the sinus, and the retrosigmoid sinus, and you have to, that's for the beginners. I think it's very, very important to know where to go. Sometimes the near navigation can help you, but it's not necessary. It's an anatomical approach to the disease. This is what is the summary of what I told you till now. And I think this is very important. Positioning. You see here that this, we are using the prone positioning. You can also maybe use the Concord position, but or the park bench position better. But this is enough. If you have a little bit of putting the head and bringing down the shoulder. Of course, you can cut. You have to cut the muscle. You found a mystery mastery that is a kind of target. You know that if you get that, you are in the good position, good planning. I'm not doing the borehole, but just making it little by little and taking out the speculum of the bone, just to show the superior sagittal, the sagittal sinus. I'm sorry, to the sinus, and after the sharp dissection. That is one of the most important things for trigeminal neuralgia. You have to find the tentorium. That means that you are going upward over the surface of the cerebellum, and you see here sharp dissection, no coagulation, and no retraction, because the gravity is retracting the cerebellum, and you can get to the point that when you go, that is the trigeminal nerve. You see here the dandy vein, and we will see later on what is the case. You can sacrifice the vein, but you have to know sometimes the anatomy before, and what is most important if there is collateral drainage. In this case, you have this one, you have another vein here, and after, of course, you find the conflict. The artery can be manipulated in a very nice way. The veins are much more fragile. I'm not using Teflon anymore for the last 10 years. No muscle, but Surgicel, the fibrillary Surgicel, that is making in time a kind of arachnoiditis for the taking out the arteries. And that is the end. Of course, this is a small vein, and because you save the big one, you can cut, you coagulate and cut. That is the only time in which coagulation is, let's say, allowed in this kind of surgery. Closure, that is quite important. You close the dura, you put some dura stuff and glue, and you can close everything. Now let's see the other situation that you can find when you have left a fascial spasm. Of course, the MRI is very important. You have to understand that in this case, you have to go where the nerve is coming out from the brainstem. Here is the vertebral artery, and you see that the nerve is hidden by this artery
that is the ICA. So you have to move the ICA, find out the facial nerve. Of course, you can use also stimulation, but that is not so important. And at the end, for the fascial hemispasmus, it's very important to put also some glue to be sure that mainly the vertebral artery is not coming back and pushing everything again. Let's finish as in the usual way. Sometimes you have the complex neuralgia, but from the same approach, you can do both things. Again, you see here a large petrous vein. The sharp dissection for the nerve, find out the conflict, take out the conflict. In this case, is the big scar, is not the perforators, and you manage to, let's go faster, to manage to take out the conflict on the nerve. And when you finish this part with the usual solar cell, you can move to the other one. And that is downward. You see here the nerve, the eighth nerve, and here is the complex of mixed nerves. Again, sharply sectioned. You clean all the nerves, and sometimes you can find also the a little bit of the you see here a little bit of choroid plexus, and you can coagulate in this case. In this case, it was not, and you put again the take out the conflict, and of course at the end you have the completely free of all the nerves. Results of this technique is quite good, as it's supported for many years, and we will see that pain relief is about in 80% of the patient free of medication, but we will see later on our personal results. Sometimes the nerves are compressed or modified in their course by some other pathology. In this way, was a micro AVM, and that was discovered by MRI. This one is DVA. You see here, this one is a small meningioma. So remember that is not the clinical situation is very important, but MRI can help you to confirm the diagnosis. And of course, you can handle the situation. This is a typical distortion of the nerve, the typical conflict you see before and after the surgery. And you see here that definitely all the fibers are modified in their course, and that's the theory of the factive transmission. It can be sustained by this imaging. Now, almost is done, but let's see some other video just to show you. You see here to show you what tips and tricks, at least for young people. This is the coagulation of the vein, because otherwise we cannot do it. And we will discuss later on when it can be done only on the visual situation, or you want to be more sure, and there is some tricks can then be done. The most important thing is no retraction. Never try to push retractor, because otherwise you can have problem with the vein, problem with the surface of cerebellum, that later on can give you complication. And always sharp dissection and no coagulation. Let's go faster because of time, and also because it's a quite repetitive the situation. On the left side that was right side. Left side is the same things. Is only that it changed. Most important things, find out the tentorium. This is the petrous bone. This is the tentorium. So you have to go on top of the cerebellum to be sure that you are not damaging the fibers and the vascularization of the eighth nerve, and avoid to have problem of hearing later on. And again, you see here that venous are saved and the second conflict can be taken out. Recurrent cases are more or less show as the same. It's a little bit difficult to reopen the craniotomy, but when you open the craniotomy and you cut the dura, you get the same situation that is in virgin cases. In this case, there was again a conflict down here, you will see, and there is no explanation why. Sometimes you can find recurrence because of a change in venous drainage, but usually it's just because the arteries that are like elastic, they come back and they make again a contact. This was the case. And this, at the end, again, the vein are saved. What about what to do when there is no conflict? Sometimes you are confident that you find the conflict, the MRI is suggesting you that, but sometimes you cannot find anything. The only things is that you can do is careful dissection. Try to go around, and we will see later on, maybe use the endoscope to see if everything is clear. And after you will have some option. In this case, I put again, just to be a kind of psychasthenic attitude, to be put something to avoid further contact, but there was no contact in this case. That is quite important, not only for the triple contact conflict that we found, but because we discussed about closing, coagulating or not the dengue vein. So let's see. Okay, let's start. Go ahead. Here you have a big, huge drain. You have to decide what to do. You can do an ICG, and you see that there is only one, looks like that is very important drainage, that is also pulsating. You can use a temporary clip for aneurysm or for AVM, as we saw Vladimir show before. You close the vein, do again the ICG, and in this case, you see there is no other way. This is very small drainage. So this vein cannot be sacrificed. And of course, you take out your clip and go ahead with the resolve, and the vein should be saved. And this is a simple trick, quite important. We are using, and I show you the video today, till now, completely microscope without using a Nevada endoscope. That was a case of the fascia spasm. You see here the nerve. But when you are not sure, or when you want to be more precise, you can use the endoscope. The endoscope may play a role, yes. There is a lot of publication that is saying that endoscope can be used and is worth to use in endoscope assisted. Fully endoscope is another story, but it can be done. It requires a long experience on that. and I will tell you what is my opinion at the end in the conclusion. So in a microscope case, endoscope should be introduced when there is not conflict, or where you are not sure that you get everything's clear. And this is one case in which there was a facial hemispasm. We put the usual way, but to be sure that everything was perfect, I stick inside the endoscope and to check if everything was what was planning in advance. And of course, there is some trick that has to be used when you introduce the endoscope. This is it can be done also with the fully endoscope approach. And I did some cases on that. This is just, these are some picture, but I would like to show you, if it's possible, one video. Let's see if I can do it. Yes. You see here, that is full endoscopic. This is beginning. There is the vein. I decide to close the vein, and the vein can be easily coagulated. Why I close this vein? Because this is another drainage. So it can be saved to close the vein.
See that? I cannot.
And when you have at the end, of course, you can be...
We cannot see the video. Please show it again.
I'm sorry. So I think that we escape. You trust me. I show a lot now. I will show you only the picture. This is the beginning. This is when you are near to the nerve. This is the resolution of conflict, and this at the end that you can make it to. I'm sorry, I cannot start the video, so I try to get this trick, but it's not working. What is the message? Advantage of use of endoscope. Able to show missed conflict, able to confirm the complete resolution of the conflict. The disadvantage is a tool that is quite large for the microcraniotomy. So, and at least the beginning is increasing a little the timing, but that is not so important. The most important thing is anyhow, the endoscope should be introduced under microscopic view, because otherwise the risk of damage of the structure is quite high. And the full endoscopic resolution of the conflict requires experience in endoscopic surgery, and I think that is not for young people or for the people that are not such a large experience. What about the results? You see here that you have almost 75%, 80% of very good results. And in a part of the poor case or the failure, you can do a second surgery, because we have recurrence also. And that's also the second surgery can be quite good. Also see if the results are less good than before. Probably because, as in the case of multiple sclerosis, the trigeminal nuclei is playing a role and has not to be undervaluated. It has to be remembered that for multiple sclerosis, the risk of the success is only in 50% of the cases, but sometimes it's worth to do it, to propose to the patient. That is the advantage and disadvantage following Giannetta. And the cure rate at that time was 70%, in our series 86%. Mortality rate was very low, in our series is nil. Yes, here. Complication, because you cannot make omelette without breaking the eggs. CSF leak at beginning was quite high, and with the sealant is almost zero. I mean, requiring surgical repair is zero.
The 3% lumbar drainage can be useful for closing, saving this complication. Permanent AIDS deficit is very low. You have to tell the patient that he can have this problem, and paralysis of facial nerve has to be put forward to the patient. Of course, there is tricks for avoid the permanent AIDS deficit. For the trigeminal neuralgia, superior cerebellar approach. For glossopharyngeal neuralgia, lateral approach, as well as for the facial hemispasm. Note sharp dissection of the arachnoid, no retraction. For avoid the permanent deficit, no retraction, sharp dissection again, and they pay attention in a case of dolichobasilar conflict, because that can be damaged in the maneuver, the sixth nerve. In case conflict cannot be found at surgery, Burkel proposed a splitting of the nerve with very good results, and that is what I'm doing today. But you can also stop and do a percutaneous procedure later, or radiofrequency or balloon technique, at least 3 months after the surgery. Radiosurgery can be one option. You have to remember that radiosurgery is getting advantage for the trigeminal neuralgia or glossopharyngeal for trigeminal neuralgia only some months before. So if you have a status of complete unbreakable pain that is damage the patient, if you want to have immediately results, radiosurgery is not the answer. And for the other nerves, radiosurgery cannot do anything. When you cannot find anything in case of facial nerve spasm or glossopharyngeal neuralgia, it's better to stop the surgery and to do nothing. There is a lot of contribution now for the glossopharyngeal nerve. They say cutting the nerve. The only few time that I cut a nerve, it was a disaster. So I am not suggesting to you. In case of venous conflict, the clipping test can be a very good way to know if you can sacrifice the vein or not. For the fascial spasm, lateral approach to the cerebellum is the trick, and it has to be respected the ICA because of the acoustic branch. Otherwise, you get good results on the fascial spasm, but you have some hearing deficit. And sometimes you have to coagulate the choroidal plexus because that is the cause of distortion of the nerve. And endoscope is a very good way to control that you are doing very good things. For the CSF leak, close the mastoid cell when you open it, just at beginning of surgery, immediately with muscle and fibrin glue. At the closure of the craniotomy, you have to try to close everything to be sure that there is no leak. And dural suture with the muscle or with some collagen structure, put the dural substitute, use the sealant, and close the surgery. Radiosurgery that is another film, another time we will discuss on that. So take-home message. The microscopic, macro, mini-invasive, mini craniotomy, microvascular decompression remain the standard for trigeminal neuralgia, for all the functional disease of cranial nerve. The important things is no cerebellar retraction, both from the superior approach and the lateral approach. Gravity has to do the retraction. The endoscope is used. It is a tool, is not the only way to perform the surgery, but each surgeon will choose what is the best strategy.
the Foley endoscopists, as I said, possibly is a question of generation. The young people that are playing with the game at the television are much more and have a better manual, visual manual strategy that my generation. What is the algorithm at the best, and what I propose to you? Drug resistance, you have to try before with pharmaceutical treatment. If you have side effect, the patient will judge, and you can make an MRI that is very important, or everything's every way, and you can have a positive found that is easy to propose and release. If the conflict is negative, you can do again, make a exploration, or go to percutaneous procedure, or go to cyberknife if you have not a status epileptic, status of trigemia neuralgia. In recurrent situation is the same. If you find out that there is a new conflict, MVD, open surgery again. If it's negative, you can propose to the patient a percutaneous procedure, or again cyberknife. These are my team, the people that are helping me, and that I guess that today are better than me in doing this kind of surgery. And I thank you for your attention.
Thank you, Giovanni. It was great. There were several questions, but you have answered them nearly all through your presentation. There is one from Dr. Sanchez from Costa Rica.
Yes.
Yes. What are the intraoperative findings after radiosurgery? What did you find?
Well, there is the arachnoiditis is more and more stiff than the usual things, but I will say that the most problem is the closure of the skin, because the skin is different than before. I don't know why, because as I show you, as I show you here, the radiation is done in a very wait, let's see if I can find it, in a spot. So I don't know why, but that is the only things that you see, that this is the target. I don't know why, but the only problem is the closure.
Okay. I have one question of my own.
Yes.
There are neurovascular conflicts described for all but 2 cranial nerves, and these are 6 and 12. How come that there are no conflicts, no something like hemitank spasms or whatever? Do you have any explanation for these 2 nerves?
The audio was very bad. Can you repeat the question?
That the neurovascular conflict
Yes.
was described in a clinical condition for all but 2 nerves, 6 and 12. Why? Do you have any explanation why there is something like a hemitank move spasms or like that in 12s, and something like
well, I have to tell you that there was described the diplopia for conflict with the megadolico-basilar with the 6th and also with the 3rd nerve. So maybe that is the anatomical situation is different. The only explanation I can say that I think that 90% of the etiology is due to the distortion of the nerve, 10%, if not more, from the nuclei. So I think that the sensory nuclei maybe are more complex that the let's say motor nuclei. To say that this can be the situation is that sometimes you have a hearing deficit during surgery for other things in the pontine angle without touching the nerve.
And I think that is because the nuclei are suffering maybe for some change in vascularization.
Okay, thank you, Giovanni. We must move forward, and I would like to ask my very good friend, and I'm looking forward to the presentation about the brainstem, Miguel Araez of Malaga. Miguel, floor is yours.